Hello and welcome to this month's edition of Dayton Information. I'm your host, Charles Williams. As many of you know, I really have a dual role in this community, both as an academic and as a clergy person. And tonight's topic is one in which I have a tremendous investment in terms of my ministry. And that is in the area of living with HIV and AIDS. This evening we're going to talk to two people that are going to explain to us about what is called the AIDS Resources Center of Ohio. And Dayton has a tremendous center that is part of that organization here in the state of Ohio. As a clergy person, I first became interested in ministry to people that are living with HIV and AIDS when I became part of a healing weekend. And it really changed my whole focus in terms of my ministry, and something of which I have received a tremendous amount of personal satisfaction. And this evening we have two individuals that have graciously agreed to come here and give up their time and help us to learn more about these services and the status of HIV and AIDS here in the Montgomery County community. And directly across from me is a lovely lady by the name of Amber Best. Now I want to make sure I get all your pedigree straight here. You're the Director of Development of the ARC, which is the AIDS Resource Center of Ohio here in Dayton.
That's
and
correct.
Prior to becoming the Director of Development, you were even on the board.
That's correct. I had been on the board for several years, and I had the opportunity to join them as an employee last August in 2015. And I am thrilled to be on board and helping with the mission. It's something I have a great passion for. And so I kind of got the best of both worlds out of it. So it's really great.
And
Thank
I
you.
appreciate that passion, because you also have the kind of work, it must give you a tremendous feeling of contribution.
Well, you know, I'd worked for the corporate world for several years, and what's really nice about working for a nonprofit, and especially one where you have an affinity for what we do on a daily basis, is that you're helping people and you know that you're giving back to the community. So it's not just a job that you come into every day and kind of look at the daily grind. It's like, you know that every day that you're walking in the door, you're doing something that has a tremendous impact on the lives of individuals, and especially those individuals that are living with HIV in the state of Ohio. So I feel very privileged and blessed to be in this position.
Well, we appreciate what you do
Thank you.
for this community, and tonight you're going to get an opportunity to share that.
I can't wait.
Yeah.
So.
And next to her is Dr. Richard Groger, and we want to welcome you, sir. And Dr. Groger is the medical director of the AIDS Resource Center Medical Center, correct?
Correct.
And this must be a tremendous responsibility and must also give you a great deal of personal satisfaction.
Oh, it's incredible to,
Tell us what you do as that with the director and so forth.
well, the clinic started about 2 years ago. When we started, we had hoped that within a year we would get to 300 patients. We far exceeded that goal.
And we're going to get into those numbers. Tremendously far
Right.
exceeded those goals.
And I am one of 5 providers. We have 4 other physicians and a nurse practitioner, plus other medical staff. And my role is just to help make sure things go smoothly, to be the cheerleader. The facility, though, really runs itself. So to be the medical director is actually a very easy job. It's a fun job and a very gratifying job to see what we've accomplished.
Okay, and you even have a pharmacy.
Oh, that's one of the
Many.
most important parts
Yes,
of our
one of the many things. And I also want to say, one of the things I learned when we were in the green room in preparing for this program is that anyone can use that pharmacy. It is not restricted. And if you use this pharmacy, those funds or profits which are made from the services they render to you goes back into the facility.
You got it.
And that's really a good deal. I mean, it's a double
It's a win-win.
win-win
It is- it is
situation.
an-
It's
it
a
is
big
an
bang
amazing,
for
great
the
thing. Yes.
bucks.
Yes.
Okay, so we've talked about what the AIDS Resources Center does, sort of. Both of you explain in the nutshell what services are offered to the community.
Well, what I can certainly tell you is we focus on HIV clients, right? So we provide specialized HIV care, but we also provide primary care to them. In addition to that, probably 50% of our employment, 50% of the people that work for us are case managers. And so we take care of the person, we take care of our clients, making sure that they have access to the services that they need. So in some cases, that might be helping them sign up for insurance, might be helping them navigate Medicare, Medicaid. But our focus is clearly on primary care and specialized HIV care. We've got certainly pharmacy services, housing assistance. Is there anything you'd like to add to that in terms of what we provide from a medical perspective?
Well, we try to do as much as we can under one roof.
That's correct.
And that's important, that for some people, it's great that they can come see their doctor, their nurse practitioner for whatever their issue is. If they need a blood draw, then we do it right there. When we give them a prescription, they take the elevator down one floor or the steps. They don't have to run around looking for everything. The other thing is that when care is fragmented, a lot of times the providers may not all be in sync with what's going on. So if a patient, many of our patients are on medicines other than their HIV medicines.
Right.
And a lot of these medicines have complex interactions. So if we are often usually aware of those, and if we're not, then our pharmacist will catch that. And before the patient gets the prescription, I'll get a phone call, Dr. Groger, are you sure that's what you want? Whereas somebody who's getting care at various places and then going to a commercial pharmacy where the pharmacist has to take care of thousands of people doesn't have that service.
Right.
We call it a comprehensive medical home
Or
model.
holistic.
It's
a very holistic.
It's very comprehensive.
Holistic.
It's one-stop shopping, and I think the one piece that we didn't mention was behavioral health. And when somebody gets newly diagnosed with HIV, you can only imagine that there's probably a level of anxiety or concern or worries about stigma that come along with that. So that's another one of the areas that we've recently made sure that we have those practitioners in our coffers, right? So when you come in, you have access to all of those types of care. And to your point, Dr. Groger, you get them all under one roof. And so we keep you and we make sure that we work with you and keep tabs on you. We will call our clients and make sure that they're coming in for their appointments. If they don't have transportation or a way to get to their appointments, we make sure that they get there. So we sort of go above and beyond what you would normally experience in a primary care practice to engage our patients fully and making sure that they have access to all the services that they need. But it's such a tremendous working environment that they have where they're able to engage with one another to ensure that that person is getting cared for holistically. And it's really, really critical.
And yes, so go ahead,
Yeah,
Doctor.
one thing I wanted to add is that each of our clients has different needs. So some people like to get their care under one roof. Other people may have another practitioner who's taking care of their HIV outside of our clinic. They may have trouble finding a primary care provider, or they might want a primary care provider who understands their HIV. So we do some primary care for people who have other people taking care of their HIV. We take care of HIV for people who have a wonderful relationship with a primary care provider, and we try to communicate and work with those people. So I want to make sure that people understand that the one-stop shopping is an option for some people, but we try to do what our clients want and what works best for them.
That's well said.
Yeah, and I'd like to add something here. Given my ministry and the many people that I've spoken to and worked with in the HIV/AIDS community, that is very important, because I could tell you horror stories after horror stories after horror stories of some of the experiences that some of these individuals went through, especially when they were informed of their HIV status. And so it's good that with the diagnosis and putting the whole care package and the whole care process into place, it's very holistic, because it's physical, it's emotional, it's social, involving the family social systems, it's spiritual. There's so many issues that are all intertwined. And as Dr. Groger said, there are other medical issues along with the HIV that you have to address and look at in terms of the effects of medication and all this sort of thing, which we're going to get into. But before we go any further, I think it's very important for us, with the viewing audience, to understand what is the relationship between HIV and AIDS, because for a while there has been a controversy of definition, and it's even changed through the evolution of the history. Okay, Doctor, you want to go ahead and take us down that road?
Right. So when a person contracts HIV, on average, in the absence of any kind of treatment, there's an average of about 8 to 10 years between the time a person becomes HIV positive and the time that that person was susceptible to infections that really were limited to people with HIV.
Oh, so there's an 8 to 10 year.
On average. And
average.
That, with
okay.
a huge variation. Some people may never progress, and some people may progress very rapidly. Before we had treatments, that cutoff, which is about a CD4, it's one of the immune cells, there was a number about 200, and if you were above that, you didn't have that much as far as risk of infection, and below that, you had progressive risk of infection. Before we had treatment, it was a one-way street. So you did fine, you hit that point where they called it AIDS, and then things worsened. The reason that we have moved away from that term is since the mid-1990s, we've had medications that could fully suppress the virus in the vast majority of people, and even people whose immune systems had declined tremendously to the point where they would be susceptible to these infections, their immune systems could come back to the point where they would be no more susceptible to things than people without HIV.
Okay, let's get into that CD count that you were talking, because most people are not familiar with that and its relationship in terms of AIDS and HIV. Could you?
Okay. So there are types of immune cells called T cells, and there's
T-cells,
a subset of those called CD4 T4 cells that are attacked by the HIV virus. And in the absence of treatment, people go from having 6 to 1,200 on average of those T cells per unit of blood to having a number which is much lower. And when it's significantly lower than the average, the person becomes susceptible to certain types of infections. And the lower that number, the more susceptible they are to an even more, to certain other infections that wouldn't even affect people with HIV, but with higher T cells.
So the higher the T cell count,
the less susceptible
you are.
Correct.
With the CDs,
Right.
So, and
Right.
so that's very important. You want those T cells up.
Correct.
You want those T cells up. And what kind of first of all, what kind of medications basically are we seeing being used now?
Right. Well, there are several classes, I think about 6 classes of antiretroviral medications that attack the virus. When medicines first came out, AZT was the first one that came out.
Right.
people who are on a single medication did well for a very, very short while, and the virus would mutate and become resistant to
And
that.
that's the other issue I think is very important for our viewing audience, is that we're dealing with a virus that mutates. And the issue that researchers have had to deal with, and correct me, the two of you if you're wrong, they can find a group of medications that would be good for one strain, but then that strain would mutate, and that same group of medications may or may not be as effective with this newly mutated strain.
Right.
Correct? Is that stated correctly?
Right. But if a person's is on usually 3 fully active drugs, the amount of virus gets so low that there's not enough to replicate to mutate. So people can be on a single medication for years and years and years without the virus becoming detectable. But that has to be very carefully monitored and tailored to that patient. So a regimen that might work for one person wouldn't necessarily work for another person.
And in the meantime, out there, the virus is still out there mutating with other individuals, correct? The virus doesn't mutate once the person is diagnosed.
Well,
Is that
usually
correct?
the virus always mutates. So but the medications select for things that
We'll
become
keep it from mutating.
the people who have partially suppressed virus, people who take their medicines some of the time but not all the time, they have enough of the drug on board that actively replicating virus that is resistant to that can now thrive and expand.
Okay.
And that's part of the importance of getting people engaged in care and making sure that they take their medications correctly. Because if they don't, that person can now develop a resistant strain and transmit that to somebody else.
Now, it's my understanding that they're starting people on medications as soon as they're diagnosed, correct?
Correct.
And it's for that, one of the reasons that you just gave in terms of the mutation?
Well, the general principle was that you always wanted to start people on medications when the benefits of the medications outweigh the risks.
Right.
Okay? And so that has never changed, but early on, the medications were difficult to take, they had a lot of toxicities, and they didn't always last very long. So you didn't get a lot of, if you started a medication back in the earlier years, you might not be able to keep someone on that medicine for more than a few years. Over time, the medications have gotten better, so that the side effects, the difficulty taking things has decreased tremendously. We've also recognized that there are benefits to starting the medications earlier. We used to think if their T cell count was below 200 that there was really little benefit, and now it's turning out that starting earlier provides benefits, that there are subtle things that happen to people with HIV without medications that are preventable. So, example, somebody who has a T cell count that's high enough that they wouldn't be at risk for infection is at an increased risk of having a heart attack or increased risk of getting kidney damage. Those risks decrease by being on medications. And that's something that wasn't recognized early on. And even if it had been recognized, the medicines weren't as good at that
Because
time.
the immune system wasn't being attacked as much the earlier you got it.
It was being attacked,
But not as much. The body could fight it.
part of the stress of the body fighting it actually had other consequences.
Yeah, and let's talk about the toxicity. And there's been a lot of debate. There's a scale here. The effect of the virus and the toxicity. And what you're saying is the medications now are having less toxicity than initially?
Right. So they're less toxic than they were. They're easier to take, and also we have choices. So a medication that may cause no symptoms, no side effects in one person might cause nausea in another person. But before, when we had very few choices. What we had is what you got. Now, if you have a side effect that affects you but not somebody else, we may have another choice for you that wouldn't have that side effect.
Okay, as with other diseases,
Correct.
with other medical conditions, as
Yeah.
with other medical
Exactly.
conditions.
If somebody has high
Yeah.
blood pressure,
There
there are
are
lots of different medicines,
medicines, yeah.
and one is good for one person and not another.
Okay.
It's actually probably easier to treat HIV than it is some of the other chronic diseases that people have.
Okay.
In some regards,
And
it's more difficult to treat high blood pressure
Yeah.
in some regards than it is for HIV.
And I want to get to that because one of the things we talked about in when I sent you the list of questions is this relationship or interaction with HIV and other sexually transmitted diseases. And especially in terms of Hep C that is out there and that sort of thing. Amber, I want you to talk about the prevalence here in Montgomery County of HIV and AIDS and so forth. Because in terms of the Dayton community, there's a lot of good news in terms of how this community is handling the HIV and AIDS situation with services, diagnosis, support, and that sort of thing. But first I want to go you to tell us about some of the statistics about how many people, what percentages,
Sure.
and that sort of thing. But if you take a look at some of the things that are happening nationally, we're really blessed here in Dayton in terms of how we have aggressively dealt with this.
Absolutely. There's about 1.2 million individuals living with HIV nationally.
Okay.
In the state of Ohio, there's about 21,000 that we know of that are living with HIV, and we think there's probably another 3,000 that might have HIV but are going undiagnosed. And so we do target those individuals. If you look at the state of Ohio, the highest area is in Columbus. So we talk about it in terms of the counties, right? So we talked about Franklin County and Columbus. Next is Cuyahoga County in the Cleveland area. Then you have Hamilton County and Cincinnati. Dayton and Montgomery County is the fourth largest population that's living with HIV in the state of Ohio. Back to the 1.2 million number about nationally. When we look at viral suppression, we talked about some of the pharmaceuticals that we have that help keep people virally suppressed. If you look at the national average, about 30% of the people living with HIV, 30% are virally suppressed. In the state of Ohio, our patients, our clients, we're running at about a rate of 80%.
Okay.
That is an amazing number when you think about the way that we treat our clients, the way that we care for our patients, and the way that we provide that care to them, which means we're doing one heck of a job in the state of Ohio, keeping people virally suppressed.
I want to reemphasize this because this is very important. What she's saying is nationally, 30% of the people are getting services that are suppressing the virus, about 30%. In the Montgomery County community, that statistic jumps to 80%.
That's correct. 80% in the state of Ohio.
And this is what I was getting to you about the aggressive action that has taken place here in Montgomery County. That means that people that have been diagnosed with HIV are receiving action, they're receiving care, and they're receiving the treatment that they need.
That's correct. Patients who are prescribed antiretroviral drugs, so nationally, another statistic, 37%, we're at 91% and climbing. Those are amazing statistics when you look at the level of care that we're providing, and it's because once we get a patient, we keep them engaged. We make sure that they're coming to their doctor appointments. We make sure that they're getting the pharmaceuticals that they need. We make sure that they're getting housing. We're making sure that they're getting access to behavioral health, the things that they need to keep them living and living a life-sustaining world, right? This is their lives. So this is what we do. It's how we keep them healthy, safe, protected. So it's
And
very
that's
important.
because that goes along with the case management approach
Yes.
that is going on
Yes.
with the entire disease. What I want to get to, and we've talked about the intake process and a lot of things that are emotional. There are a couple of other things I want to get to. And the two programs I want to get to is PEP. The two are PEP, P-E-P, and then there's the PrEP, P-R-E-P. So PEP and PrEP. So let's deal with these. I'll let either one of you that want to talk that want to talk about these two.
Well, I'll tell you, it's probably one of the best tools that we have in our arsenal. I'll let you talk about the two differences between the two of them. So.
Okay. Well, first, with HIV, one of the main goals is not just to take care of the clients that we've got, but to prevent people from acquiring HIV in the first place.
Right.
And for about 3 decades, we've been focusing on education, which is a terrific tool, but the rate of new cases of HIV nationally has been stuck at 50,000 per year, year in, year out. So what that meant was that tool, prevention, was clearly not enough. So that's where other things come into play. Clearly getting people who are HIV positive into care, getting them virally suppressed is a very important part of prevention. Treatment is prevention, because if somebody has an undetectable viral load, the risk of transmitting to another person is very low. It's not zero, but it's very low, substantially decreased. The other group of people are the people who are HIV negative. Some of those people know that they are at risk, high risk for acquiring HIV.
But have not yet acquired it.
Have not.
Right, have not yet acquired it.
And over time, if they do nothing other than what they have been doing, we know that a significant number of them will get HIV over time. And for those people, we have a clinic. We offer what's called pre-exposure prophylaxis. First, education is still the mainstay of this.
So we're talking about people that could potentially be at risk because of lifestyle?
For lifestyle, correct.
Right, okay.
And
lifestyle, could involve drugs?
We talk about men having sex with men, people who inject drugs,
sexual
and
behaviors.
potentially sex workers. So.
And we also have partners, life partners of people with HIV for whom the partner
that's correct.
does not use protection. So
And goes outside the conjugal.
They may not, but they may be HIV positive, not suppressed, and not use protection.
Oh, okay.
So,
in other words, they could have been HIV prior to coming into the marriage. Is that what you're saying?
Correct.
Or it could happen if the person goes outside the marriage.
Correct, or relationship.
Okay. Relationship, right.
Right. So for those people, there's a medication, one of the components of our HIV medications, which can be given to that person daily, and that significantly reduces the risk that that person would acquire HIV. It doesn't eliminate, but it tremendously decreases that risk. And that's called pre-exposure prophylaxis.
Okay,
That's PrEP.
all right.
That's PrEP.
All right, so let me make sure that I get this clear. If a person is having, let's say, or is electing to have unprotected sex, and outside a relationship, or not in a relationship, is engaging in risky behavior.
Correct.
So this person can openly go to a counselor and explain this, and be given the medication.
Correct.
Okay, and acknowledging or admitting that he or she is involved in this behavior.
Correct.
Is this what,
Right.
okay, this is what you're saying?
We openly discuss that, and the
person has to obviously self-disclose.
Correct. But they do it but the thing is that this is a very non-judgmental setting. They know
Right,
that
and that's
what
the
we
point
do.
I wanted to get at. That's the point I wanted to get at, the non-judgmental.
Well, and I think it's also important to understand that it's not just, you don't just come in and make an appointment and you get a pharmaceutical. There's a protocol that goes along with that. You have to come back in every 3 months and get testing.
Okay.
You have to go, we do provide education. We do talk about sexual behaviors. We talk about things that will keep you, we talk about the use of condoms. I think there's, we have tests that they are given beyond just an HIV test at those 3-month intervals. We look at kidneys, we look at other vital organs, but we make sure that the individual is on a schedule to receive ongoing care. It's not just you come in and you get a prescription. I mean, we have to make sure that we're managing their care.
There's accountability
absolutely,
afterward.
in
There's
a very
accountability
responsible
within
manner.
this process.
That's
There's
correct.
accountability.
And we often, we screen and often find and treat other sexually transmitted diseases that the patient was not aware that he or she had and could also have transmitted.
Okay. So let's go, and I'm going to pick up on that issue. Let's go to the PrEP. We have the PEP,
PEP.
now let's go to the PrEP.
Reverse that.
Reverse that.
So that was PrEP,
PrEP,
pre-exposure.
okay, that was PrEP.
So
Let's go to PEP.
PEP, not everybody who is at risk for acquiring HIV knows that he or she is at risk for HIV. So sometimes somebody may have an accident. They may be having protected sex with a condom. A condom could break.
Mm-hmm.
They may have sex with a partner that they believe that they thought was HIV negative. It may be a stable partner, and they find out that person is HIV positive. There is a short window after an exposure during which time a patient can be given medications that, again, don't eliminate, but tremendously reduce the chance that that person would seroconvert and become HIV positive.
And that window, I believe, is 72 hours, you said?
We say 72 hours. The earlier, the better.
Mm-hmm.
So it might be helpful at 72 hours, but if the person can call us that day and say, here's what happened, I'd much rather see them immediately.
And they can get in immediately for preventative measures?
Well, we do what we can. So we try to accommodate people as best we can. So for example, if someone calls in and say they've had an exposure, we try to bring them in. Obviously, if somebody has an exposure on Friday afternoon, we would not be able to do that with our resources.
Okay, now could a person go to an emergency room and have the same kind of treatment at an emergency room?
They could. Again, it's just a matter of what the provider does. So there's no reason it couldn't be done in another setting.
Or your
but
family
I can't-
doctor, possibly?
Absolutely. But and there, for all of these things, there have to be multiple routes for people getting it. So for
Absolutely.
example, pre-exposure prophylaxis, we encourage many other providers to do that because we want as many people to have access to these options as possible. And we may not be the best option for some people, but this is one, we like competition. I'd much rather have as many people getting what they need as they can. We don't want to corner the market.
Right.
And we give free advice to other providers to try and guide them through.
Well,
So-
it's education. I mean,
Yeah.
we would much rather have people understand what the drug provides and what are the positive aspects of it. We'd much rather have them educated and knowledgeable about it than worrying about whether or not that's our patient or not. We want people to get access to care.
Well, PrEP, so that we can review here, PrEP is strictly preventative.
Correct.
The prophylaxis.
Correct.
You always think of prophylaxis as preventative. You go overseas and they put you on a prophylaxis as a preventative for a particular kind of like malaria and what have you. So that's preventative. The PEP is if an accident happens.
Correct.
And it's an emergency action.
Correct.
Okay. And one other thing, and I think also that I want to emphasize that it is non-judgmental. That the purpose of both of these programs is health care. Okay? Good health care and not judgment. And this is very important because we're going to be talking about this toward the end, about attitudes in society and that sort of thing. So we want to be sure that everyone realizes that this is non-judgmental, and what we are talking about here is good health care and not making any sort of judgment on the person. The next issue that I want to get back to is we were talking about HIV and other sexually transmitted diseases. We all know gonorrhea, chlamydia, syphilis, and especially in this area, syphilis is really on the increase, and Hep C. Now, from what I have been, from what I've been told, right now, Hep C could be more dangerous or detrimental than even the HIV. Now, doctor, now this is what I have heard. I would like for you to expound upon that and tell me whether that is true information, whether it is false information. I have been told that penicillin is no longer used for gonorrhea and so forth, that some of the medications that are used for HIV now are even being used for gonorrhea. So could you please give us an assessment and the status quo of the other diseases as it relates to some of the HIV medications?
Okay. Well, as far as the danger of HIV compared to the danger of hepatitis C, it's really more difference in access to treatment, access to medications. So prior to antiretrovirals, the vast majority, probably 90% of people with HIV who without treatment would ultimately die of that disease.
Right.
With hepatitis C, it's estimated that about 20% of the people with hepatitis C without any kind of treatment would progress to end-stage liver disease, cirrhosis. So the numbers, both things untreated, the hepatitis C was much less dangerous. With HIV, there is now availability of medications for essentially everybody with HIV, so that the death rate from HIV, particularly on people in care, has really, really decreased. And the life expectancy of people in care taking their medications is essentially approximates the lifespan of other people in the society, people without HIV.
Okay, could you please repeat this? Because this is one of the most important pieces of information I hope we can get through this program. Sir, could you please repeat that?
Very simple. Somebody with HIV on medications in treatment can live an essentially normal life, both in length and in quality. That's about as simple as you can get.
And that is a wonderful
That is a wonderful
reality.
thing.
When I think back at the history and the days when I saw in the 80s this disease crop up.
Now,
That is a wonderful reality to be to that point now.
Well, we started providing end-of-life care, right? When
Right.
this organization started in 1984, getting an HIV/AIDS diagnosis was a death sentence. And so this organization focused on how do you care for that individual and help them with end-of-life care. That's not what we do today.
You extend the life.
You have a normal life. If we can get you treated, get you on the right group of medications, you can live a normal and healthy life.
Okay. And my apology, doctor,
Oh.
please continue with the question, but I'm sorry, that is such a magnificent
Absolutely.
revelation for people to know that I just had to uplift that. Please continue.
with hepatitis C, even though only about 20% of the people with hepatitis C would progress to end-stage liver disease, and many of them die from that disease, There are now medications that can essentially cure hepatitis C in more than 90% of people with hepatitis C. The problem is that very few people can get that.
And why is that?
The cost of the medications.
Okay,
It costs about
let's get into that.
about $100,000. It costs about $100,000 to cure hepatitis C, and there's not the same public investment of funds to provide that. With HIV, it's still very expensive to treat. It's probably what, $1,200, $1,500 a month.
About a month,
Right.
over
Yeah,
the
a
course
month.
of a lifetime, it might be $300,000 or $400,000
Right.
over the lifetime of an individual.
Now.
Now.
But our society has decided that it's a priority and provides those funds for HIV, but not yet for hepatitis C.
Because there was a time, I mean, if you work with people that have gone through this journey, there was a time in this journey in which it wasn't always that easy to get those drugs. A lot of people had to deal with a lot of struggle through the system because they didn't have the ARC and some of these other organizations to help them to struggle through that system, especially people that didn't have insurance and what have you. In terms of the Hep C, are the insurance companies, those medications, are the insurance companies for people that are lucky enough to have insurance, are they being covered?
Often not. So with hepatitis C, similar to HIV, the earlier you treat, the better off you are. Many of the insurance companies will not cover the cost for people with early disease. They wait until a person's liver has a significant amount of damage. And they also often deny coverage to people with conditions that can worsen their prognosis with hepatitis C. So for example, if somebody has hepatitis C and drinks to excess, that person's risk of progression to end-stage liver disease is greater than if they had either of those risk factors, the hepatitis C or the alcohol alone. The alcohol doesn't make them more susceptible to hepatitis C or reinfection, but most of the insurance companies would say they won't pay for it if somebody actively drinks. From a medical standpoint, those are the people you want to have the highest priority to treat.
Because it seemed to me, though, that if they let the disease deteriorate, then the person would be qualified for a liver transplant, which is even more expensive, correct?
Well, let me give you an analogy. Let's say right now, if I were to take your blood pressure and I found that it was high, maybe it was 180 over 110, I would start you immediately on medications to keep your blood pressure lower. And I'm not doing that to treat your blood pressure, I'm doing that to reduce your risk of heart attack or stroke.
Mm-hmm.
And if I catch it early when you have no symptoms, I have the greatest chance of success. If blood pressure medications were significantly more expensive, it would be analogous to saying, we will only pay for your blood pressure medicines if you've already had a heart attack or a stroke.
Okay.
That's a good analogy.
Yeah, so in other words, they're letting the condition deteriorate and then taking the action.
Right.
Okay. What about with the other issues told me with gonorrhea and that sort of thing? Some of the medications that are being used are actually some of the medications used for HIV. Now that's exactly what, I don't know if that is true. That's why I'm asking a physician.
No, it's not true for that. The only thing that may have some hepatitis B, some of the medications that treat HIV can treat hepatitis B, and hepatitis B can be transmitted many ways, including sexually. But other sexually transmitted diseases, such as syphilis or gonorrhea, are not treated with medications that are used to treat
They're
HIV.
not. Okay, so is that just regular penicillin and antibiotics, or?
Well, again, each illness, each sexually transmitted disease
Has
has
a
its own
different strain,
treatment.
has its own strain.
And resistance patterns always change, so it's just important that the treating provider be aware of what is likely to work. and what has changed in the area over time. So,
Okay.
and from the patient standpoint, it's just a matter of getting into care if they have symptoms or risks for sexually transmitted diseases.
I said I wanted to get to attitudes a little bit more because, as I said, as a clergy person and working with people in the community, I've seen the effects of attitudes. And I think it's very important with these two programs, the PrEP and the PEP, that it's very important that people can take advantage of these services without judgment calls being made. Because we live in a different society, and sexual attitudes and practices certainly have changed. And we're living in the era of pansexuality. We're living in the area in an era in which people are exploring their sexuality in a more open fashion. And it takes me back to the time in which AIDS was first diagnosed. And it took us a long time to acknowledge this as a worldwide disease, that AIDS is not something that affects just certain people. It affects everyone within our society and all of our young people. What can you tell me about people's attitudes nowadays? Are we getting better? Are we getting worse? What is happening, especially in this age in which sexuality has completely and totally changed?
Well, clearly there is still a stigmatism, there's still a stigma attached to the word AIDS and HIV, as we see that all of the time. If you look at what we have within our own, under our own roof, we have the ARC Ohio Medical Center, but we don't call our pharmacy that. We call our pharmacy the AMC Ohio pharmacy, because we have people that are concerned about walking in there to get their prescriptions, right? They don't want to be associated with it. So clearly there is a concern and a stigma that's still attached to it. We try very hard to make sure that people are educated, that they understand. We do that through our prevention programs. I think one of the things that we're seeing is that age group, that 15 to 29, those are some of our highest risk youth, and so we're trying to get to that.
Unpack that as to
well,
this.
it's just, I mean, those
Yeah.
are the individuals that we're trying to get to, so that we can help educate them, so that they understand what it means to be safe and to have safe sexual behaviors and to have safe sex practices, because we don't want them to have the HIV virus, right? We want to protect them from it. So we spend a lot of time through education, through protecting our youth, through the programs that we offer through ARC Ohio to reach them. But there's still a stigma attached to that. I think you might have see that still on the patient side.
One of the questions that you had asked earlier about why it took so long to get to where we are and why we haven't gone so far with HIV is that for many people, it's always been viewed as other people's illness or a lifestyle illness. And one of the things that I want to emphasize is that when you think about an illness or condition being related to lifestyle, then if I sit in front of the TV with a bag of potato chips, I'm also putting myself at risk for a lifestyle-related illness. So,
Guilty.
what exactly?
I'm
Okay,
guilty.
exactly. So,
I'm guilty.
so I think from a societal point of view, I think that the more people realize that, gee, we're all doing things. We're all having different risks, and maybe we should be very careful about judging other people. And that takes time. I think that it takes time to understand. A lot of people now, again, people living with HIV often do very well, when people know somebody with HIV, they maybe they realize, well, but that's Jim. He's I have no problem with Jim. And then they realize, yes, maybe it's their own kid or their brother. The more that people understand that these are just other people just like them, I think that will help improve some of these attitudes, improve some of the stigma that is a barrier to care and literally kills people.
And like the 13-year-old.
Oh, I was just going to say,
yeah.
we have an amazing program that most people don't know about. It's called Camp Sunrise.
Okay.
And it is for children. So we have kids 6 to 16 that can come to camp for free in the summer. And they're usually children who are living with maybe a parent who has HIV, or maybe they themselves are HIV positive, and they can come and go to camp for a stigma-free week. And so they get to be kids for a week and go to camp just like anybody else. But while they're there, they talk about what happens when you're treated differently by somebody else, and how do you manage that, and what do you think? And so we have programs that can help address that with those certainly those young ages. If you think about someone who's 6 or 7 years old that might be living with someone who is impacted or affected or at risk of HIV, so we can address that with them. But I mean, what we want them is, we don't want people to have a barrier to care. And I think that was really well stated the way you said that. We want people to feel good about coming to ARC Ohio, especially to our medical center and our pharmacy. We want them to feel that it's a safe environment, that they can come there and they won't be judged. I mean, they're going to be able to have conversations, and they're going to have access to the care that they need. And not just for HIV, it can be for their preventive care, for primary care.
And I just want to add to that there are, within the spiritual community, there are healing weekends where that exact same atmosphere is created that you talked about. It's a safe place where people come together for weekends and deal with the spiritual healing of living with HIV and AIDS. And that's how I first felt a calling to serving and working with the HIV and the AIDS community, is working through. I had the opportunity to work at one of those weekends. And there are experiences out there like that, and they're very important.
Yeah, absolutely.
They are so important to know.
They're life-altering. They can be life-altering for people.
And it's like, I can imagine what it would be like for a family that would have a 13-year-old that has been diagnosed with HIV. What are the schools doing, or how are the schools, do you feel, dealing with these issues?
Well, across the state of Ohio, every school system is different, and so they can put in place their own programs. So it's hit or miss getting into some of the schools, but we try our best. We have healthy relationships. We have healthy families programs that we do, where we're trying to get to those age groups the best we can. When you see young adults that are older, we're going out into the community. We're going to the health fairs. We're getting to them the best we can. For those that are older, it could be going into a nightclub in the evenings and talking about HIV prevention and doing HIV testing.
And I know that's being done a lot.
It
the
is.
Outreach especially to the nightclubs and the bars. Yeah.
So
that
every
is being
age group
done,
is
right.
different in the way we approach them, but we are doing our best to educate, teach prevention, talk about safe sex practices, and so it's across the board. We just want to continue. We know we need to continue to maintain that focus and make sure that people are safe and healthy.
Okay. And one final question before we wrap this thing up, and I think this is going to be a positive answer. Are we winning?
We're doing a lot, but I'd like to see us be able to do a lot more.
We certainly have the tools in place to keep people healthy and happy and safe long term. We just need to make sure we continue to do that, and we just need to get a hold of them and keep them.
So we're certainly on the road to
Absolutely.
victory. We're certainly on. the road to victory. And I want to thank both of you, and I want to publicly thank on the air all the fine work that is done through the ARC, the AIDS Resources Center, and everything that everyone is doing in this nation to combat the situation, and all the people that are in the helping services, the doctors and the healthcare workers and providers and the researchers. I want to thank them all and to thank you for the wonderful job. It must give you a wonderful feeling at the end of the day to know that you've made such a contribution to this community
It's good.
and to
Thank you.
individuals. Thank you very much.
Thank you.
Well,
And I
we
want-
appreciate the opportunity to share our story. So
Well, it's an honor for us to do it. And we want to thank you very much for watching. That concludes this month's edition of Dayton Information. Thank you very much.